First of all, to introduce myself, my name is Sanjana. I am one of the founders of Miara. And today we're very excited to be talking to Dr. Jayashree Gopal. But first of all, just want to give you a little bit of brief of what is Miara. So Miara is your guide to midlife health. We are a science and evidence-backed platform to support women in perimenopause, menopause, and beyond. We offer different services in which include information and awareness through our website, blogs, and social media. We offer personalized health and wellness programs for women, which are science-backed. And we also provide information and access to at-home diagnostics and products in India. Another thing that we do offer is corporate sensitization awareness and workshops in communities where we talk about perimenopause and menopause, which is a rather taboo subject. In the chat, you will see the links to Miara. We'd be happy if you would follow us on socials as well as check out our website. And today, our speaker today is Dr. Jayashree Gopal. She's a senior consultant and endocrinologist and diabetologist at the Apollo Hospital in Chennai. She's also the director of Diab Endo India Chennai and has received, and also a diplomate of the American Board in Internal Medicine and Endocrinology. So she has got a lot of awards and has done a lot of great things in the field of endocrinology and diabetology, but I let her share that and her experience with us talking about metabolic syndrome and menopause today. So thank you, Dr. Jayashree, for joining us today.
First of all, thank you. It's wonderful to, come here and talk on this Miara platform and talk about something that's very close to my heart. You can see in the bottom right, the foundation that I've set up. It's called Diab Endo India Foundation, but the tagline is preserving health across generations. And below that, the Tamil translation reads that if we are healthy, our offspring are healthy. So this is what we try and do to make sure that create awareness about the importance of health, not only for ourselves, but for our future generations. Of course, today, what I'll be talking about is something slightly different. Again, a topic which is very close to my heart. And since I have passed the menopausal transition and sort of lived to tell the tale, there are some things about the current sort of approach to understanding that I may not agree with. So I'll share my views and, what does the science say to some extent. I just put up this picture because I was Googling, as usual, images on menopause. And this is one of the first few that came up. And I thought, why would you want to sort of have a picture where there is like a pause on the femininity symbol? I mean, I thought this whole thing was very, it's not right, obviously. So many more aspects to it, so many more layers to this, but I just put it up to start it off as a talking point. But this is one of the first few symbols that come up, and I thought it was an interesting way of looking at menopause. And I always like to go back and look at, why did things evolve the way they did? So, for example, when I start thinking about thyroid hormone, when I start thinking about the various hormones, vitamin D, for example, it is the earliest hormone to have evolved. So there are vitamin D-like molecules in bacteria. And among the earliest sort of things like insulin and insulin-like growth factor evolved much later, but vitamin D is one of the earliest hormones to have evolved. So in that way, looking back to, why would even we need menopause? Why can't we just keep on giving birth? Quite apart from the fact that some of us may choose not to, but why is there this sort of biological phenomenon of menopause? And of course, I'm sure people who have been reading about it know that there are these two main sort of theories put forward regarding this. One, that it was an event that increased reproductive success. So the fact that there were a generation of women, older women, who could help their daughters look after their daughters' offspring, so their grandchildren. So the so-called grandmother hypothesis meant that very, very early stages, when man was just beginning to evolve, this served as a way to help human beings survive. So that's one hypothesis. And the other, which I actually ascribe to, is that it is just an event which is a byproduct of living longer. If you look at menopause across species, at least in mammals, it has been reasonably well studied. And pretty much most of the species that have been studied do exhibit a loss of the reproductive capability beyond a certain age. But only humans, whales, and certain species of elephants, the Asian elephants, these are the only species which live for any length of time beyond that menopause, beyond the ability to reproduce. Most species would die soon after they lose that reproductive ability. But in captivity, for example, chimpanzees in captivity do have a period of their life which they spend after the menopause, after their ability to stop reproducing is over. So it does occur. What is the biological need? What is the sort of socio-cultural context for it? That's a different aspect. But for some reason, it has evolved, and it may be one of the reasons why we have evolved the way we did. So maybe it's a very important aspect of what makes us human. Of course, there are a lot of symptoms ascribed to menopause, and this is one of the many that you would get from the internet when you look for it, things like brain fog, and we'll talk a little bit about it. I think some people had put in questions about bloating and brain fog, and we'll talk about how some of these may or may not be related necessarily to the menopause. Some of these are related to the menopause, and I'll go through some of them, but I just put it up to say that a lot of things which are ascribed to the menopause are not necessarily related to the menopause. I think it's related to other changing aspects of our physiology. So a lot of these changes are probably part of getting older, the normal process of getting older. And all of the hormonal systems in our body slow down as we get older. At a recent conference, I used the term, I said something to the effect of, we're all dying a slow death every day, or we start dying from the day we are born, and it did not go down too well. It was an audience of doctors, right? And they got very upset. They thought I was being too morbid. But it's the truth, from the day we are born, our cells, being a biochemist, Sanjana, I'm sure you agree with that. So this is what happens. Our bodies change, our physiology changes. And, the menopause transition is one of the changes, a very dramatic change for some women, but it is one of the many transitions which is occurring in our body. So one of the myths, which I don't ascribe to at all, is that it is a hormone deficiency disease. It is not a hormone deficiency disease. It is a natural biological change. It is a natural life event. And similar to how the ovaries are sort of starting to work less by the time you enter your late 30s, early 40s, other organ systems in our body are also starting to slow down. So we are making less, for example, growth hormone. That is what is referred to as the somatopause, adrenopause. Certain of the hormones from our adrenal gland are coming down. After the age of about 80, the thyroid gland starts working less effectively. The pancreas, the functioning of the pancreatic beta cells to make insulin also starts to slow down. So a lot of the hormonal systems in our body are slowing down. This is the natural process of aging, of getting older. In some people, it's accelerated. It may get accelerated in certain diseases like diabetes, but this is a natural, normal process. The other myth is that you can prevent a lot of the problems that are ascribed to menopause by taking hormone replacement therapy, and this is not necessarily true. And we can talk about, the sort of Women's Health Initiative and all the findings from that. But taking hormone replacement therapy is useful for symptomatic relief. So some women find a lot of benefit in terms of their hot flashes, or in the way they look, or in the way they feel in terms of their skin. But a lot of the biological changes that are occurring anyway, you cannot reverse just by giving a combination of estrogen and progesterone hormone, whether we give it in a natural way or whether we give it, in sort of the bioidentical hormones or the synthesized synthetic hormones, whichever way you do it. You cannot completely reverse the changes which are anyway going on in our body in other aspects. So I think to some extent, there has been this medicalization of menopause, which sort of parallels Obviously the availability of contraception, which started around the 30s and 40s. I'm not negating the need or the use for hormone replacement therapy in certain situations. I think it's very important, but to label 50% of, or whatever, the population of women, every woman who goes through the natural menopause, saying that they have a hormone deficiency state and need to be put on hormones, I don't ascribe to that. And interestingly, if you look at it as a cultural phenomenon also, there is no word for menopause in many languages. There are some equivalents to which are considered the closest to menopause. For example, in Japan, apparently there is this term, which is generally the term used for someone who's getting older and wiser. If somebody knows Japanese, they can correct me. Again, in China and Taiwan, older women who've stopped having their periods and generally looked upon as very wise women who have seen everything, who know a lot. In Tamil, our native language, there is no word as such for menopause. So just to say that it wasn't considered, there is a modern Tamil version of it for us to be able to talk or to, for the media and to explain to people, but there isn't any sort of general term that was used for menopause. So whether we consider menopause, sort of a state that makes us into a psycho, or whether it is something that sets us free, obviously these are two extremes, and the truth, as always, lies somewhere in between. The fact about menopause is that there is a gradual decline in the functioning of the hypothalamo-pituitary-ovarian axis, the whole hypothalamo-pituitary-ovarian axis, which is a very well coordinated sort of, it's almost like a symphony. I think of it as a symphony. So there is a gradual slowing down, and this slowing down actually starts from the day we are born, literally from the day we are born. This change accelerates when we are in our late 30s. It comes to a halt when we are in our mid 40s to late 40s. The natural age of menopause is somewhere between 45 to 55 years. And menopause technically is when you stop having your periods for a year. The ovaries stop making eggs on a regular every month basis. It is associated with a fall in many hormones, including estrogen and progesterone from the ovary, and it may be associated with some symptoms. But it is a myth to say that horrible symptoms occur, that you're going to be sweating all the time, you're hot. Sometimes I find that some women are just so worried about the process of going through the menopause. They haven't been through it, but they think it's going to be some really horrible phenomenon because they've heard something about it, or they've seen some other of their family members suffering, may or may not be related to the menopause, that they get worried about it. It is true that for some women, the symptoms may be severe. The symptoms that have been associated with the menopause definitely related to the estrogen deficiency are hot flashes, vaginal dryness, urinary incontinence, and lack of sleep. Sleep disturbances, I'll put it that way. A large majority of women, more than 3/4 of all women, transition through this perimenopausal period with very mild symptoms. And I can tell you that personally, probably the only thing I noticed is a little bit of an increase in hot flashes, which, I had to think really hard as to what I had. And there wasn't much by way of symptoms, honestly. It's another myth to say that menopause is associated with depression. It's not true at all. The sleep disturbances probably cause a lot of the mood changes. Again, this is a transitory thing. It tends to happen because of the fall in the estrogen. You tend to wake up more easily. Though you may go to sleep, you sort of wake up, that's that very disturbed sleep, and that causes the tiredness and this general lethargy in the daytime. Depression per se is not a natural consequence of an estrogen deficiency or the menopause. Similarly, osteoporosis after menopause, the bone density does reduce after the menopause, but the increased risk for fractures is not inevitable. I always like to show this slide. This is a slide which compares your bone mass versus the age, and you can see that you reach your peak bone mass by the time you're 20. It's fairly stable till you're 50. After the menopause, there's a little bit of a decline. And then you have the slow decline that occurs because of age. By 70, 80, you have a more of a fall in the bone density. However, if by the age of 20 you've not reached your peak bone mass, obviously then you are at a higher risk of fractures because you don't have enough in your bank balance, as it were, and you're more prone to fractures. So it's not inevitable, and certainly something that can be prevented. Now, coming to the purpose of this talk, metabolic syndrome. And metabolic syndrome refers to this constellation of various factors, but at the very basic level, it refers to this coming together of high blood pressure, high blood sugar, high cholesterol, and excessive abdominal fat. So excessive weight or excessive visceral adiposity increased in the abdominal fat. Why do we need to worry about it? Because this constellation, this coming together of blood pressure, sugar, cholesterol, and the tummy fat is an indicator of underlying insulin resistance and inflammation. And it is one of the strongest predictor of most diseases of aging, most what we nowadays call non-communicable diseases or diseases of aging or chronic diseases. A lot of these diseases have their origins in underlying metabolic syndrome, insulin resistance, and inflammation. This is a concept that has evolved in the last sort of 20 years. In the mid to late 80s, I mean, maybe in the early 80s, people started recognizing that people, one of the risk factors for having a heart attack or a stroke was obviously, we knew about high blood sugars, pressure, but they also knew that the blood was more sticky, there was abnormal clotting of blood, and that there was high cholesterol. And in the mid to late 80s is when it was all put together in this so-called syndrome X or insulin resistance syndrome. They realized that all of this came together because the body's insulin was not working properly. And then further it was refined, and we understood that it was primarily related to increased body fat, predominantly fat around the abdomen. So this is what ultimately causes the metabolic syndrome. Now we are beginning to understand that this insulin resistance and inflammation also increases risk for other non-communicable diseases that we attribute to aging, various types of cancers, liver failure, liver disease, depression, dementia, sleep, other sleep disturbances like sleep apnea, PCOS, the list goes on, arthritis. So a lot of these diseases that we ascribe to aging have their roots in the 30s and 40s when you start gaining weight around the abdomen and start developing this insulin resistance and inflammation. So is there truly a link between menopause and metabolic syndrome? That is what I'm trying to sort of tease out today. And again, it is a myth to say that we will gain weight at the menopause. It's very easy to blame the menopause, very easy to blame hormones for a lot of things that is not true at all. There is a natural tendency for both men and women to gain weight as we get older. And that's around 0.5 kilo per year. That's about the average. The only thing that changes in the menopause is that we tend to have a tendency of, at a younger age, we have more fat in our bottoms. As we get older, we tend to have more of that fat accumulation around the tummy area. So like how men have this apple-shaped obesity, women also have it. So menopause does not appear to cause weight gain, independent of what is happening because of age. The only thing is that the distribution of the body fat changes. And another very important aspect that occurs because of that, partly because of lack of estrogen and mostly because of lack of exercise, is that we lose a lot of our muscle mass. There's reduction in the lean body mass. Women in general, particularly Indian women, have less muscle mass to begin with, and we don't make any effort to preserve it. We don't make any effort to maintain it. And anyhow, from the ages of 40s and 50s, independent of the menopause, it starts coming down even more. And what about heart attack? Heart attacks and menopause. Again, that's a very big concern that women after the menopause are more prone to heart attacks. And half of all of us are going to die of a heart attack or a stroke. Hopefully that shouldn't happen for many more years yet, but that is the truth. And the risk of this heart disease or stroke increases after the menopause. And by the age of 60 to 70 years, men and women are about equal in their incidence of having a heart attack or a stroke. So estrogen does protect women before the menopause. After the menopause, estrogen deficiency, the lack of estrogen puts the risk of women on par with the men. The protective effect of estrogen is lost. And this was a sort of a graphic which just showed the other changes that occur partly because of the weight gain around the tummy area and partly because of estrogen deficiency. So because of this excess fat mass, excessive insulin resistance, there is also a reduction in muscle mass. There's a reduction in insulin secretion. What I was trying to explain earlier, the metabolic syndrome. These changes occur. However, it is, I would say, somewhat of a myth to just ascribe the higher risk of heart disease after menopause just because of the estrogen deficiency. The risk does increase, but it's also related to age. And most important, the higher risk is not reversed by simply giving estrogen. In fact, if we use estrogen hormone, the hormone replacement therapy, if we don't do it in a proper controlled fashion, it actually increases cholesterol levels and increases the clotting of blood, increases the risk of a heart attack or a stroke if we give hormone therapy for much older women after they have, say, 5 to 10 years after the menopause. If you suddenly expose them to hormones, the first 1 year after they get put on hormone therapy, there is an increased risk of having heart attacks and strokes. And most important, this risk of which is increased after the menopause occurs even in premenopausal women who have diabetes. So if you have diabetes, or you're a smoker, or you have high blood pressure, or you have high cholesterol, the protective effect of estrogen is not there any longer. You lose that protective effect of estrogen. So even a 30, 35, 40-year-old woman with diabetes, we all have patients, early 40s, we come across women who come in with atypical chest pain and they turn out to have a heart attack. And the only risk factor is either diabetes or blood pressure. So it is a myth to think that premenopausal women are always protected against heart disease and postmenopausal are exposed to a risk. The truth, like I said, is always in between the two. So how do we maintain health? I think that all of us know, Miara does it. I think these are the three most important. You're never too young to start healthy practices. I think healthy practices start from when you are in your mother's womb. You have to be lucky if your mother was healthy. If your mother was healthy, chances are you're going to be healthy. Maintain your health so that your baby is also healthy. If you're healthy during pregnancy, your baby is also going to have a good health later on in life. Strength training, very, very, very important, especially in this day and age where most of us, don't do enough to maintain our muscle strength, our bone strength. So strength training, starting from a really young age. I just call it strength training. You may do yoga, Pilates, actual strength training, whatever it is, but muscle strength is also equal to bone strength. And avoid weight gain. Once you gain the weight, particularly after pregnancy, it's very difficult. I mean, yes, you can lose the weight, but then it takes a tremendous amount of effort to maintain that weight loss. So I think avoiding weight gain in the first place is the most important thing. So women who gain weight during pregnancy need to lose it in the first 1 year after delivery, because after that it becomes difficult. The older we are when we get pregnant, particularly after the age of 35 to 40, if you become pregnant, it gets more difficult. So we just have to be very, very fit before we plan a pregnancy and make sure we lose all that excess fat as soon as delivery is over. And these are all some of the things that we can do to maintain our health and prevent the loss of the protective effects of estrogen. So finally, I don't think menopause is a disease. It's obviously just a natural life change. Some metabolic changes do occur due to estrogen deficiency, but a lot of the metabolic changes are because we're just not looking after ourselves. We don't pay attention to our health between the ages of 30 to 40. And some of the changes are because we are getting older. Can we prevent these metabolic changes? Yes, with a good, healthy lifestyle, starting from a young age and not with hormone replacement therapy. I think that was my very brief introduction to the topic. And like I said, I set up the foundation partly because of this. Most of our diseases are man-made, and we really need to take care and make sure that we maintain good, healthy practices every day so that we can at least postpone. We are not going to never have diseases, but we try and maintain good health for as long as possible. I'll stop there and very happy to answer questions. Thank you again.
Yeah. Thank you, Dr. Jayashree. It was actually very refreshing to hear from a medical professional that, menopause you don't need to be extremely stressed and worried even in your young days about this menopause time. I think that's really refreshing to hear medical professionals talking like that, and not this fear mongering that we hear in the media and things. So thank you for that and this concise talk about the various things. I'm opening up the floor for questions. So a lot of the questions that we got were about this weight gain that you mentioned. So how you did speak about how to prevent it, but once people have already gained weight, for example, during this time, so what are the steps that they should take, during this perimenopause time, if they have gained this abdominal fat and stuff like that? What are the steps that they can take immediately to, get started on this, to lose the weight and prevent this metabolic syndrome?
Unfortunately, I don't have the magic bullet. I wish I did. But I think it's consistent, constant. I think the three most important things: you have to eat less, you have to eat less often, and you have to eat less carbohydrate. Ultimately, it comes down to that. Particularly for Indians, a large part of our problem is we think we are healthy because we are vegetarian or we have whatever, an egg occasionally, but we are not healthy. We're just consuming too much carbohydrate. But ultimately, we're also eating too much for what we are burning off.
And also
So
could it be
eating,
the factor of like nutritional deficiencies and things like that, which could also impact not losing weight? Because there have been some studies which have said with obesity and stuff like that, if you're deficient in D vitamin or things like that, it also impacts weight loss.
well, all those are associations. So in general, people who are obese tend to have lower vitamin D levels because a large part of the vitamin D is actually stored in the fat. Whether the vitamin D deficiency is causing the weight loss, nobody knows. Causing the weight gain, nobody knows. Certainly, just giving vitamin D supplements is not helping people lose weight. So I don't think nutritional deficiencies play a big role if you are, otherwise well nourished. Of course, things like, yes, if you have iron deficiency or vitamin B12 deficiency, you may have an altered appetite. You may feel like eating certain things, but that's a different matter. Whether it causes weight gain, no. I think it's just ultimately years and years of eating too much and it catches up.
Yeah.
And if you're blessed with a good metabolism, that's good, but that's very rare. There are some people, no matter what they eat, they won't gain weight. They have a good metabolism. They have a higher brown fat, or they have whatever, different things. But a lot of us have to make that effort constantly to either lose weight or to avoid weight gain.
But the question is, does metabolism actually change during this perimenopause time? Like if you talk about how your metabolic, because people tend to say that. So I want to know if that's a myth or there's some truth in it or somewhere in between.
Well, it's somewhere in between. I think it's, so the other way to answer this question is, if you have a young woman in her 20, who's 30 years old, who stops having a period, someone, what we refer to as premature menopause, she's not going to gain weight. Okay, so it's not just the fact that you're going through the menopause that's causing you to gain weight. Yes, the estrogen deficiency makes you more likely to maybe gain weight around the tummy area, but most of that weight gain is happening because our metabolic rate is coming down. Metabolic rate declines, I don't know the numbers, but like 20%, 30% each decade of life. So it's coming down. So we have to put in even more effort, even to just keep up our metabolism. That's why I said strength training.
I have a question. Can I?
Yeah, go ahead.
Hi, doctor. It was absolutely fabulous hearing from you.
Thank you.
That correlation between aging and menopause itself, not often do we hear that. Because like you said, everything is attributed to that life stage itself. Every horrible event is attributed to this monster called menopause. Now, as you're talking about this weight gain, the question that I have is, let's say someone has been consistently training, in her 30s and 40s. There are still changes that she experiences towards menopause, isn't it? In spite of having, is that because of the natural process of aging and the lowered metabolism? Because even good lifestyle does not insulate you from some of the changes that happen physically with menopause.
Absolutely. I mean, that's why I said all other And it's not just the ovaries which are working less. It's your whole growth hormone axis, which is working less. The adrenals, your DHEAS is coming down. So the whole sort of anti-aging, market, as it were, looks at replacing multiple hormones. So I think to a large extent, you can minimize the impact of getting older. You can delay a lot of the diseases, but it's not sort of, you can't do it indefinitely. But definitely, yes. I mean, I think you'll find that when you're in your 50s, you have to put in even more effort either to lose weight or to even maintain the weight compared to what you were doing when you were in your 30s.
Mm-hmm.
Definitely your metabolic rate comes down. But I'm saying it's not just the menopause that is causing that.
Yeah, absolutely. And therefore, I think it becomes that much harder for women to accept that change, isn't it? That it's because of aging that some of these are not as effective as it were perhaps when we were in our 30s. It's almost like we are finding something to attribute the cost to. Is that what's
Absolutely.
going?
But I mean, it's not to exclude that menopause is a factor. I think that's also the point. It's not excluding it completely, but there are also other factors in play. I think that's also something to be.
Yeah, I just don't want people to think that menopause is the factor and then decide to get on to like hormone replacement therapy. You can see I'm not at all a fan of HRT. I mean, I do use it, but not for, like, for example, for weight reduction or for metabolic aspects.
Mm-hmm.
So, we use it for certain things. So, unfortunately, like you said, you want an easy sort of low hanging fruit. You want something which says, oh, it's because of that I'm not losing weight. I knew it, and maybe if I take this pill, I'm going to be able to achieve that. And yeah, the more we work with weight reduction, the more we realize that whatever efforts we take has to continue. Earlier I would tell people, okay, once you lose your 8 kilos or 10 kilos, okay, maybe you can come off the medicine. Maybe if you're on medicine, or maybe you can relax the diet a bit. And what I've realized is, no, you have to be as paranoid about the diet. You have to continue taking the medicines. Otherwise, the weight comes back on. That's why I said prevention is key.
Mm-hmm.
Avoiding that weight gain, particularly the first 1 to 1.5 years after pregnancy for women, I think is they easily balloon from like 60 kilos to 100 kilos. And then it becomes really difficult for us to get them to maintain the weight loss.
Yeah. So there are a few questions on the chat. So this is also someone who said about the weight gain. I'll just maybe mention it. So weight reduction do we need to focus on weight reduction post menopause, or can we address weight reduction during the menopause process itself? I'm just checking so that to avoid putting more stress on the body during the menopause phase. So I guess the question is,
I mean, you can take all the efforts you need to during the menopausal transition. You won't be putting more stress. And certainly you can make all the effort that you need to.
Mm-hmm.
There is no concept of waiting till the menopause. Prevention is key.
Mm-hmm. And there's another question, is there a connection between vitamin D and reproductive hormones like progesterone or estrogen?
Again, associations. Vitamin D is extraordinarily important. I started off by saying it's the earliest sort of hormone that evolved. No study has consistently shown it to be, again, the magic bullet. That becomes a problem, just giving vitamin D to everybody, it's going to treat the infertility, or it doesn't happen like that. But it's important to maintain your vitamin D. What the normal values are, in India, we measure it in nanogram per DL. So around 30 to 50 is considered a good level. We try to maintain it there. Mm-hmm. And most of us are not going to be able to get enough vitamin D with sun exposure. At least I'm saying the quantum of sun exposure that you need, with the pollution, with the fact that, you have to go and stand at 12 o'clock to get the sun's rays at whatever, 90 degrees. So for all that, I think it's easier to take a supplement.
Yeah, I've gone through total hysterectomy recently. I've kept my tubes and ovaries. How will menopause hormones affect me in the next few years? Should I constantly monitor my hormones of estrogen and testosterone levels? Please advise, what should I look forward to?
people who've undergone a hysterectomy tend to have an relatively earlier menopause. They think it may be because the tubes are tied off. So compared to someone who has the uterus intact, maybe the ovaries will sort of start working less, maybe a couple of years earlier. I think a lot of the, you don't necessarily need to monitor your estrogen and testosterone. If at all, you're looking to see whether your ovaries are working adequately, the hormone that I generally monitor is FSH. That gives you a good idea of how well your ovaries are working. And again, prevention. I come back to exercise, diet. That helps you sort of go through the menopause transition quite easily. The only thing where HRT, I think, helps necessary and does not really have side effects is this vaginal irritation and vaginal dryness, for which we can use estrogen creams. And I think it really helps. That's about, so local estrogen application, I think, is helpful.
Okay. I hope that answered your question. The other, we didn't touch upon thyroid too much today, but does perimenopause, is it related in some way? Do women start experiencing thyroid changes during this perimenopause time? There were some questions about that as well.
Yeah, not necessarily more than normal. I think what tends to happen is that because you're coming with some symptoms, your doctor just runs through a battery of tests, and it'll include a vitamin D, it'll include a thyroid, along with everything else, trying to find an answer for your symptoms. And thyroid problems in general become more common again with age. So 1 out of, I think 8 to 10 women, by the time you're 70 or 80, is going to have a thyroid problem. And this number is something like 1 in maybe 20 women when you're much younger, in your 30s. So it's more a factor of aging. Menopause by itself does not necessarily lead to increased incidence of thyroid problems. It may be picked up more often because you're going to the doctor for something else, but by itself, it doesn't increase the chances of having a thyroid problem.
Okay. Then also some specific questions about diabetes and menopause phase and struggling with weight gain in spite of exercise. Someone said, I'm unable to diet, and the weight gain is pronounced around the center. Based on my height, they've said their height and weight. So please help address this issue, they've said. I don't know. Diabetic plus
Like I said, it's, I mean, people with diabetes, I think it's also more difficult. It depends upon the types of medicines. There are some medicines in diabetes which prevent weight loss. So you need to make sure that you're on the proper medicines that actually aid in weight reduction, even if you have diabetes. And it comes down to eating less often, eating less carbs. Every time you eat something with carbohydrate, your body makes insulin. Insulin is an anabolic hormone. It makes you gain weight. It's not easy. But the reason I keep mentioning that is because, this, even though I'm saying eat less often, eat less carbs, I'm saying it easily like that. It's just, it requires a lot of discipline to actually do that consistently. It's not easy at all, but at least it explains why, when people say, oh, I'm not eating anything, but I'm gaining weight, or I'm not able to lose weight, it happens because you have not reduced it enough. And I think beyond a certain point, the more I see, I think I've discussed this with some people here, ultimately, I don't think it is about the weight. It's about your fitness, obviously. It's about are you losing the little, at least, even if you lose about 2 or 3 centimeters or 4 or 5 centimeters around if you lose 5 centimeters from your tummy area, most of your chronic diseases will be cured. So, and I think there was one of the questions that was sent in saying, in spite of exercise, my weight is not going down. I mean, if you're losing the centimeters, don't worry about it, would be my brief answer, I assume. And if you're getting more fit, don't worry about it.
So like BMI and all is probably not a great measure of, I mean, because people just directly look at 1 or 2 parameters or 1 parameter like weight. So it might not just be that, is what you're saying. So that's interesting to know for everyone.
Yeah.
It could be inches, it could be just activity levels and, fitness levels and less fatigue and things like that as well. Another question was about belly fat and bloating intolerance towards many foods like dairy, millets, fiber, egg. Is that a common occurrence amongst perimenopausal women?
Again, I don't know how much of that is perimenopause, how much of that is age. I think a lot of people in the 40s and 50s certainly develop lactose intolerance. They develop intolerance to various foods. In Indian context, milk is a big culprit. Wheat for some people. Dals, particularly tur dal. Certain vegetables, onions, potatoes, beans, different things. And I find in the summer, for example, fermented foods causes a lot of problems in summer, having your idli, dosa, just the fact of fermentation. So yes, I mean, if you're not comfortable eating something, try not to eat it. But it definitely, again, I'm saying, I don't know, definitely our digestion changes as we get older, and we have to change our food practices with it.
Yeah. And I think that also comes to the fact what Miara also tries to do is to help women be self-aware and like know that their body is changing, and, even tracking food or tracking your diet and things like that. So important. And that kind of goes to mention, because if something doesn't agree with, don't eat it. Like it should be as simple as that. Can insulin resistance be reversed?
So I like the term remission better.
Okay.
There is a lot of, these people claiming to reverse diabetes.
Yes, exactly. That's right.
So I think the very appropriate term is remission, because it doesn't let you, it doesn't mean that all of us, I mean, anybody can do it. If you get onto like a pure vegetable diet for the next 1 month, you're going to be you will lose 5 kilos. And if you have borderline sugars, it will come down. Your insulin resistance will reverse. Will you be able to maintain that for the rest of your life? True reversal means at the end of your 1 month or 2 months or 3 months, you can go back to eating whatever you want and you'll be fine. And that will not occur.
Okay. Yeah.
So you need to maintain that really strict sort of low carb diet, high fiber. You need to be able to maintain that consistently. And then very definitely it is possible to have a remission of your insulin resistance and your diabetes, everything, cholesterol, all those things I've listed there, fatty liver.
So from an evolutionary perspective, is it better to always eat low carb, high fiber diet for everyone? So is that or is it like at different phases as a woman, I'm saying, at different phases, do we require different components of food and then therefore, or is it just?
Not at all, not at all, not at all. I think, I mean, when you're trying to lose weight, I think low carb helps. But certainly if you're growing up in an environment of plenty, you need to make sure that you're eating less. And that has to start when you're young, because now we are facing this problem with children who are coming to us with obesity and diabetes, all the other problems. So it's never too early to start. And it's also not necessarily true that, in fact, the Indian guidelines, for the first time, they've said for the Indian diet, you can get it down to 150 grams of carbohydrate a day. The National Institute of Nutrition, their guidelines. So they've said you can come down to 150 grams because carbohydrate is like sacred here, right? So they've said that you can come down to 150 grams. I think only in pregnancy, they said some 175. But even in pregnancy, there have been studies where people have followed very low carb diets, though we don't necessarily advocate that. But you can consistently, we've been able to help people achieve about 100 to 120 gram carbohydrate diet. Even if you're vegetarian, you can still maintain that. You can do it, you can maintain it for the most part. I'm not saying it's 100% of the time, but you can do it, you can maintain it, and it does not need to change during pregnancy. Because pregnancy is the only time you're worried about it, or breastfeeding, you're worried about it. But you do not need to change in those times. As long as the baby is growing well and you're able to produce enough milk for the baby during the feeding, the lactation period, that means your nutrition is fine, it's good.
There's a question in the chat. Are there any recommended blood or other tests that women should get done regularly post 40 to detect metabolic syndrome early?
Yeah, I think that's an excellent question. Thank you for that. At the very basic, I think it's important that you check your sugar, a fasting sugar and a HbA1c, a lipid profile, particularly with a triglyceride and a HDL, your uric acid, which is again a marker of inflammation, your liver function test, because fatty liver, again, is a marker of insulin resistance and inflammation. I check something called a CRP or HSCRP, C-reactive protein, which is a very, or a ESR for some people. Any one of those things, for example, a slightly a reduction in the platelet count, an increase in the WBC count and your complete blood count, even that can be a subtle hint or a subtle clue towards insulin resistance. But at least these other things, the sugar, cholesterol, lipid profile, uric acid, HSCRP, liver function test, yearly once, I think is a useful exercise. Some people also do the fasting insulin to calculate something called the HOMA-IR to see how well is your insulin working. But I think you get a lot of the information you need from these other tests. Sometimes I do the insulin level, but I don't find it particularly helpful.
Mm-hmm. And with these test results, it's best to go and see an endocrinologist. Is that?
Absolutely.
Yeah.
Absolutely.
Okay, because...
you know, even when the HbA1c starts going above 5.8, 5.9, start getting paranoid.
Okay. Paranoid
Because,
by meaning start working out or running, start running.
That's what I mean. That's what I mean. Start getting paranoid about your lifestyle. Because what happens here is, unfortunately, even when you have a HbA1c of 7, most doctors would say, just starting stage of diabetes, don't worry. But the fact that your HbA1c has reached 5.8, 5.9 itself means that your insulin resistance has reached a tipping point. Your body is not able to make enough insulin to keep up with that insulin resistance.
Yeah.
So take that seriously. Take that seriously and start working on it.
Okay, that's important. Decrease in WBC suddenly, anything related to menopause? Somebody has asked the question.
It sometimes happens after a viral infection. So the first thing we do is, if you've had a cold or something recently or the flu, then we just wait for a week or 2 weeks and repeat it.
Another quick question. How highly are gestational diabetes and higher risk of linked to higher risk of diabetes during menopause?
So having a history of gestational diabetes itself puts you at high risk of diabetes later on in life. Not necessarily just around the menopause time, but at any age. So GDM is sort of like we call it a stress test for later development of diabetes. But it's also, the reverse is also true. If you've had gestational diabetes, it also gives you that opportunity. Quite often we find people who've never had any medical issues and they come and they suddenly have a HbA1c of 9 or 10. So if you have gestational diabetes, if you start looking after your diet and exercise and monitor regularly, you can prevent, you can postpone the onset of diabetes. I mean, like I said, some people suffer a lot more from hot flashes. And interestingly, now studies are coming out saying that people who suffer more from hot flashes are also the ones who are more prone to develop this whole metabolic syndrome. So it seems to be some sort of a marker of an underlying, maybe a hyperinflammatory state. For us, the more challenging question is, what do we do in that situation? So if it is a person with diabetes, we have to be careful about the type of hormone replacement therapy we need to choose. So if they're having disabling, significant, frequent hot flashes, we do have to consider giving HRT. If we say, okay, fine, maybe we are not considering HRT because the sugars are not under control or the blood pressure is high or the cholesterol is high, then we have to consider using medicines which come under the category of antidepressants, which have also been shown to reduce hot flashes. So medicines like Prozac, there's another one called venlafaxine. These are the ones that we use for hot flashes if we do not want to use hormone therapy. But even if the depression has its onset at the time of menopause, we do not consider depression as a reason to initiate HRT. There are only certain accepted indications for HRT. One is disabling hot flashes. And that's pretty much it, actually. And vaginal dryness, we treat with estrogen cream. Osteoporosis was considered sort of an indication. Severe osteoporosis, maybe HRT. For sometimes the problem with the HRT is we can only use it for a brief period of time. We can't just indefinitely keep on giving it. And like, for example, suppose I say, okay, you're having disabling hot flashes and I need to give you HRT. Anytime I try to take you off the HRT, 6 months, 1 year down the line, you're going to be still go through that period of disabling hot flashes. So we have to do like a very slow taper. So it's only sort of postponing the inevitable in some ways. So to answer your question, if someone has depression along with the menopause, I would treat the depression as an independent thing, how it needs to be treated. Yes, I understand maybe some sort of hormonal changes around the menopause or other life events. More likely the life events around the menopause are the ones that precipitate depression. So that is handled and treated as an independent problem.
That's interesting. How does working out help with insulin resistance? So is it just the weight loss part of it, or does it alter the metabolism of, like, just in terms of the science of it?
The weight loss is a very small part of it, I think. It's to do with the fact that you're building up your muscle. I think that's a large part of it. And when you exercise for up to 18 hours after your exercise, your insulin receptors are in a state of readiness, waiting to come to the cell membrane and pick up the glucose and take it in. So yeah, so the GLUT4 transporters, whatever the GLUT4 receptors are there waiting. So exercise helps in multiple ways. The weight reduction is only one aspect of it. In fact, I personally don't think exercise is a good way to lose weight unless you're working out, 3 to 4 hours a day. So exercise is good to reduce your insulin resistance significantly, but not because you lose weight.
Okay, that's good to know. And when you say low carb, just to end it there, but when you say low carb, do you mean high protein, low carb?
Not necessarily. So just to give the context, most of our Indian diets, average Indian diets contain anywhere from 300 to 400 grams of carbohydrate per day. When we are talking about something like the keto and the paleo diet, where people go into ketosis, we are talking about carbohydrate intake of less than 20 grams a day, which is almost impossible in the Indian context because you have to leave out cereals and pulses. Pulses also contain quite a bit of carbohydrate.
Right.
That's why I said what we can achieve is a low carb. I mean, this 100 to 120 grams a day that for most people I would say is doable, manageable. It doesn't cause dramatic weight loss as what you would achieve with the paleo and keto, but it does not have the very high amount of fat that you would get with a paleo diet or with a keto diet. I don't necessarily, I don't agree with the amount of fat that some of those diets prescribe. High protein, again, it's a little bit of a double-edged sword when you're a vegetarian, because apart from soya, you don't really have good sources of protein, which is going to not increase the carbohydrate. So I think the high fiber becomes a useful part of it. So it's moderate protein, I would say, high fiber, a lot of vegetables. That's why I said, we have to accept the fact that when you're going to eat less, you're going to go hungry for a while. So there's just no other way around it. It's till your stomach size shrinks and you get used to eating less, you have to go hungry. You have to get through that period of getting used to eating less.
Eating less, yeah, that's important. Yeah, I think, I think we've kind of.
If there's time for one last question, I have one.
Okay, go ahead.
Sorry. So this is just sort of to, I think currently both the medical fraternity and women are sort of divided between this whole HRT being prescribed pretty easily, and women also seeking out HRT as a solution. Vis-a-vis, practitioners like you who are very clear about how this whole HRT needs to be doled out. Now, for the average person like us, like women, how do we even make that judgment call, to say no to HRT when it's being offered to us, and also to go out there and seek it actively? I think that'll be really wonderful to have today, because I think that's where all of us are. We are hearing a lot about, go out there and ask for HRT. So if
I wish there was an easy answer. Honestly, I don't have an easy answer, but the one thing I would say is a lot of the symptoms that are ascribed to your menopause are not necessarily because of the menopause. Look at your diet. Look at your diet. A lot of the symptoms that you're going to go in with bloating and tiredness and fatigue. I saw, one of the pictures I put up said fog, brain fog. We find a lot of the brain fog going away. I call it carbohydrate fog. So, I mean, that's a well-known term. People who get into low-carb diets know that they think better, they feel better, right? So, a lot of the symptoms that are ascribed to menopause are not necessarily because of menopause. It's because of eating things that are not suiting you at that stage in your life. So, look at your diet, look at your exercise. I personally only think the main indication for hormone replacement therapy is disabling hot flashes, and that too for a brief period of time. If my doctor offers me HRT, the questions I would ask are, do I absolutely need a doctor? Why are you giving it to me? So that's the first question to ask. Why? Why are you giving it to me? Beyond just I'm in the menopause, is there a specific reason you're giving it to me? Second, is there any potentially health issues I have which can get worsened because of the HRT? So I would 100% check my CRP, my C-reactive protein. Do I have inflammation? Do I have a fatty liver? Is my triglycerides high to begin with? Because the estrogen is going to push it up even further. So do I have any health conditions that can potentially get worsened because of HRT? Third, and the more, I think, equally important question is there any alternative? Do I really need to be on it? Is there any alternative to HRT that you can suggest? How long do I need to be on it? What is going to happen when I come off of it? Is this going to be for the remaining 30 years of my life or 40 years of my life? No. Is it going to be for the next 6 months? Is it going to be for the next 3 months? Can I do without it then? Why do I need it if it's only going to be for the next 3 months or 6 months or 1 year? So this is the way I would approach it. I don't know, does that answer your question?
Absolutely, because clearly now I think both the market and people are so divided. I think this was very, very relevant. At least I know the kind of questions that I need to ask before I choose to get on it. Finally, the decisions are ours, but at least I can make a well-informed decision of whether I want to get on it or not. So thank you for that, Doctor.
I think, yeah, that's what it's very important to have the well-informed decision and the doctor to be able to tell you that and help you make that choice for yourself. Like you said, vaginal estrogens, for example, are useful for, those kind of, vaginal symptoms that you have during this period. So it's good to, I think a lot of people just don't even know or never have had that conversation with a doctor about it. So it's good to have that perspective.
And can I just say, sorry, before we finish, I have to make a point. So all that I have spoken today is about women who undergo the menopause after the age of 45 or 50, the so-called natural menopause. This absolutely does not apply to women who undergo who have the menopause before the age of 40.
Mm-hmm.
In that age group, I don't think there is any doubt that giving them the hormone replacement therapy helps, at least up to the age of 40 or 45. So premature menopause is a whole different, scenario. Mm-hmm. So this is the natural menopause that occurs in most women after the age of 45 or 50.
Mm-hmm. Yeah, that's very important to mention that it's not the same rules for both. Absolutely. Okay, so I think that was great. Thank you so much, Doctor. I think this is really great to get your perspective from an endocrinologist, especially because, you have this deep knowledge of the hormones and what goes on in the body, not only the sex hormones, but also insulin and thyroid and everything. So thank you for your perspective. And it was really nice to have you on our platform. And hopefully we'll do more such conversations with you in the future. Thank you all for joining.
Thank you.